Dr. Kamal Kapur, he doesn't need an introduction. He is going to talk to us the future of cataract surgery, how the trend is changing. What he said is bifocals are probably going to be obsolete. Now you have either an EDOF or an EDOF monofocals. So he is going to talk on magnificent EDOF lens, which is going to be in a future of the cataract surgery where monofocals are going to be obsolete. Dr. Kamal Kapur.
A very, very good afternoon. I think, first of all, I must apologize to the speakers whose turn I'm jumping. I've got an IC coming up. So I think a wonderful session. I just add a few points to Dr. Jermaine by the time they start with my presentation. Hydroinsertion of the phakic is an excellent idea. Lesser rotation, lesser change of vault in the first 1 week. But yes, sometimes if the loading is not perfect, it can tilt and twist and cause cataracts. And another big plus point of this is that you have a stable vault. So your planning of the second eye can be very fast. If you put a viscoelastic, you can have a variation of the vault. So having said that, I'll be coming to the topic of EDOFs. This is probably the new kid on the block. They're probably not so new anymore. A lot of us are using these lenses. But I actually feel the era of monofocal lenses probably is over. The era of bifocal is getting over now. See, the iatrogenic presbyopia created by the surgeon, the holy grail has been the presbyopic correction. And are the EDOFs or the enhanced monofocals the holy grail? Because gone are those days when you need, all the patients are so demanding, they want more near vision. I have no financial disclosures for this particular presentation. So is this the missing link, the enhanced monofocals or the EDOFs? I'll go very fast because I will rush for my IC. So actually this is a huge presentation, but I'll be just talking about these few points. When we talk about the EDOFs or the enhanced monofocals, we play with the spherical aberrations, we play with the chromatic aberrations, and we also play with the refraction diffraction. What is the role of the pupil size, especially when you're talking about enhanced monofocals and EDOFs, corneal surface disorders, and the patient selection? So most major categories you'll see of all presbyopic correcting lenses would be the multifocals, which would be diffractive, refractive, enhanced monofocals, the EDOFs, the pinhole lenses, and the accommodative lenses like crystal lens. Principles or mechanism of action would be a diffraction, refraction, or the pinhole mechanism. The principles, again, I will not go into the details. Actually, an EDOF is defined as a lens which gives you a continuous zone of focus with a very, very slight loss of defocus or a blurring zone. So these lenses will subserve majority of your day-to-day functions provided you have a right patient selection. You don't have a bad cornea, your astigmatism is well within control, your biometry is totally online, you will get excellent results. So this actually stretches your focal point onto the retina. Unlike the multifocal lens will give you zones of clear, zones of blur, zones of clear, zones of blur. So the multifocal patient can give you or complain to you of a waxy, washed out image. Now this is what a monofocal lens would probably appear as, a single point crisp photo image. A diffractive bifocal will have two sets of focus with a zone of blur in between. And a trifocal will have three sets of focus with a zone of blur in between. Now these sets of focus are according to the distance. Now let me tell you, the patient's height is also a very, very important feature when you're doing these presbyopic correcting lenses. This lesson I learned long, long ago when I ventured into the presbyopic lenses. Tall patients will tend to be more happy. They have a longer arc length of the arm, so they are very happy. So very good patients are tall patients. I am 6'1½", I would be an ideal patient for EDOF because I'm 55, I don't need reading glasses. I'm a hypermetrope, I don't need reading glasses. I still can just move a little bit, which is still very comfortable for me and do the work. But a shorter patient will need a near eye. So you need to decide, seeing the physique of the patient also. I see so many audience smiling here, probably I've given them something new. Everybody is nodding their head. So when you have a shorter patient, you need to play with the micro mono, or you need to probably go in for a trifocal. In an EDOF, you have a stretched zone of focus, which is not a crisp, discrete zone of focus. There is no zone of blur in between, a slight elongated zone of focus. Now let's understand the spherical aberrations first. We all know a positive spherical aberration is when a peripheral rays through a lens are meeting before the focal point. And the negative spherical aberration is when they're meeting behind. What an enhanced monofocal lens like a magnificent or an Eyehance does is it just plays on the negative spherical aberration. It just gives you a longer zone. So then the question is, why not play it more? Why not give more negative spherical aberration and get a better depth? We'll see why we can't do that. There is a limit to that. If you start playing with it, the peripheral image, when the pupil dilates, starts getting distorted. So there is a very small zone which you can play with, the probably a near of anything between 0.75 to 1.5, 1.75. You go beyond that, you'll have peripheral issues in your zone of vision. So the last slide you see is something which would be playing on the negative spherical aberration. Now add on it the diffractive nature, like Symphony or other lenses, where you will have another add for near work. Now what would happen if you overplay the negative spherical aberration? The peripheral image or the dilated pupil will get distorted. So you have a safe zone of playing maybe 1, 1.5, 1.75, and you can get away with it. This is again a classical example. Now this is what would look like, taking a photograph through a highly spherical aberrated fisheye lens. Now enhanced monofocal lens, I have a huge experience with this magnificent lens. Probably more than 4,000 lenses implanted, very, very happy patients. And over time, I think I was one of the first ones to realize that it really does well if you do the non-dominant eye first. When you're playing, especially for both eyes, do the non-dominant eye first. And I correct the first myopia on my optical biometer, which is anything less than 0.65. The first myopia is my target, and the second eye is emmetropic. These patients do phenomenally well. We'll share something with that. The American Academy of Ophthalmology describes a EDOF lens as any lens which does not take away 6/9 or better lens, and yet in 50% of the patient gives you an intermediate vision of N9. Now, the comparison of the logMAR scale, as this previous slide says, that it has to be 0.2 logMAR. So 0.2 logMAR would be approximately, if you go here, if you keep moving on there, it's 6.9.5, 6/9.5, which means the patient should be unaided 6/7.5, and for near N9. If in more than 50% of the implanted patients, you are achieving that, you can be classified as an EDOF. This is a very, very loose definition, but it's being tightened now. Now, this is the last definition which I talked about. So just describes what I just told you. An EDOF will give you a zone of clarity which is much broader than a monofocal lens. A monofocal lens, you will have a crystal clear vision at a distance beyond or 6 meters and beyond infinity. But in EDOF, you will have a far clearer vision even in the nearer zone. A monofocal will start behaving this as the lower image as the object starts coming nearer. But the EDOF will continue to play with a slight amount of edge blur and still make you do your daily work. Now, this is a huge chart. I'll just talk about, we'll talk about EDOF and monofocal enhanced EDOFs. Brought two categories. A hybrid would be any lens which has spherical aberration built in with diffraction or refraction. Or a true EDOF would be only lens which is playing only on your spherical aberrations and chromatic aberrations. These are various lenses. I will not go into that. Vivity is a classical example of a true EDOF, but it is based on a beam scatter or a beam focus technology. I've had a lot of experience with Vivity. Vivity is an excellent lens, but can give you waxy vision in some patients. When the pupil size is not under control, I've used a lot of these lenses, isopure lenses also. So I have a large set of experience with all the lenses. So in my armory, in my practice, this lens magnificent fits beautifully well. It's cost effective. Most of the patients can afford it, and majority of my patients, I'll share my okay, this is something interesting. The area under the graph of MTF will decide what is the amount of light energy the patient is getting and what is the amount of clarity in the zone of depth he can work with. So in the EDOFs, you have a maximum number of area under the EDOF graph, the MTF graph. So you have a long range of clarity of vision with least amount of loss of vision, unlike a trifocal where you have 3 bumps. The patient will see clear at one point, blurred, see clear, blurred. So there's a loss of energy in between. In an EDOF is a continuous decrement, so it's a continuous zone of vision with no intervening zones of vision. The Technis High-Ends, which is probably the next comparable lens to the magnificent, boasts of a probable, the literature says 1.5 diopters of near ad in the central zone, but if you actually get into the optical bench studies, a lot of them say it's anything between 0.89 to 1.12. So the average is 1 diopter. So you're actually seeing a 1 diopter of a near ad in these lenses. Whereas the magnificent in a radius of 1.5 millimeter is actually going to give you 1.75 diopters equivalent of a myopia, which is a fantastic amount of depth. Now, I will share our experience in a set of group of patients we did. We could see patients seeing N6 bilaterally with blended vision. 68% patients in my clinic are N6. N6, both eyes open. That's phenomenal. And when I shared this data with the company, they say it's not possible. We didn't make this lens to do this. And that's when I shared with Sanjay and the team that that's what I'm doing. I'm playing around with the bilateral blending. So this is how the lens is actually designed. The central part will have a higher dioptric power than the periphery. So in a dilated pupil or any pupil more than 3 millimeter, you will have the complete power of the distance. When the pupil constricts, as you bring the object nearer, the central part kicks in and it starts. I'll just jump these slides. So this is the 4,000, more than 4,000 IOLs done. So case selection is important. You need to tell the patient, the language we use is 80% of your daily life, you will not require glasses for near vision at all. That's the opening sentence. So the patient is already mentally programmed. And we tell them, if you want to read a medicine label, you want to thread a needle, you will need glasses. Once you plan and program the patient for that, and if he gets more than that, he's more than happy. So these enhanced monofocals like magnificent are more forgiving, no halos, no glare, no dysphotopsias, far more better range of patients, even in borderline surface disorders, borderline ERMs, borderline maculopathies, glaucoma patients, you can use these lenses, so your range is much wider. And one interesting point is, if you used a monofocal in one eye, you can jolly well put a magnificent in the other eye. So 30% of my practice is in the second eyes, I'm putting a magnificent lens where I put a monofocal lens. So I guess I'll skip it. Thanks a lot.
Thank you, Dr. Kamal Kapur. It's as you said that, I mean, probably the monofocals are going to be obsolete when you have an advanced monofocals in our practice, like how trifocals have taken over the bifocals. Next, I request Dr. Rajesh Fogler.
Yeah, sure.
Please.
See, the magnificent comes in a toric also. 0.75, and I still do a steeper axis and I do an OCCI. Even at 0.75, I do an OCCI. I need to see whether I have an against the rule or with the rule astigmatism. I prefer doing an OCCI even if it's 0.68 because it gives me a better depth. A lot of times the text will tell you that 0.75 and below you can do away with it. But in case you are comfortable doing OCCIs, go ahead. In case the incision site permits you, a lot of times you'll have the nasal part coming in, you cannot do that. But in case you can, try and reduce the astigmatism as much as possible and you'll have very happy patients.
In this, the company doesn't really tell us how their lenses work. They're not.
I told you.
No, they haven't revealed it. So how do you find it different from my hands? So I also find the results with Magnificent to be better. So,
See,
really what is the difference?
Yeah, I just shared that. The company, the Technis says that they have a near ad in central 2 millimeter. The literature and optical bend studies, if you go into it, say it's anything between 0.92 and 1.12. So the average is 1 diopter in 2 millimeters. Here they are saying that in 3 millimeters, they are giving you 1.75. So it's a little wider zone. And so the smoothing is very gradual. So the tendency for you to have the edge blur is lesser because it's a larger zone, so they have a long area to taper off at the periphery. If you have a shorter zone and you taper suddenly. So I think that's the trick they have. They have a lot of tricks up their sleeve, even in their trifocals and tridefs. The amount of the gating phenomenon they do is amazing how they managed it.
Kamal, do you have any experience with AdTech comfort lenses? AdTech.
AdTech, yes, I have. In fact, I said most of these EDOFs I've used them and moved on. AdTech is a very good lens. In my hands, I feel it has folds. Anybody who's used AdTech here, raise your hands. Winters, you will have folds in the center of the lens for first 3-4 days also. Some of the times it will disappear. Any lens more than 22.5 diopters, I can show you 20-30 videos which I showed the company. So first they thought it was an injector issue. They changed the injector with me and I was working closely with them. I think it's a material issue. Most of the lenses will lose these folds as the lens opens inside. You'll see 3 classical folds, the longest in the center and 2 smalls at the side. You wait. You see the first day post-op, they don't go. Most of them go 3rd, 4th day, but some of them, they don't. So these are material cracks. These are material cracks. They may not bother the patient, but as a surgeon in retroillumination, they bother you. It's like Acrosoft. Glistenings don't bother the patient, but they bother the surgeon. It's something like that.
Thank you.
Thank you.